So, fun fact.
Yeah, what is it? Yes, Matt, what is your fun fact?
So, fun fact. Heroin is actually a brand name.
Really?
Yeah. It was developed by Bayer Drug, the same company that made aspirin,
Wow.
as a alternative, a less addictive form of opium. Yeah, that worked.
Oh my gosh.
Yeah. So you can legally prescribe it in the United Kingdom to treat pain. The generic name is diethylmorphine, but they took this medication, they branded it as heroin, and said, "Yeah, here, try this." And yeah.
Oh, what was it pill form or something?
No, it was IV, I think. That I don't know.
Oh, so they would give it to him in the hospital.
Wow.
You can order it. I mean, that's where they give it. But it's like any other pain medication, or like any other opioid. It's works the same way. It's just highly addictive.
And you saw that movie that's coming out on, gosh, I forget which streaming, Hulu maybe. It was called, oh God, now I'm not going to remember the name of it. But it's about
Hydrocodone?
Was it hydrocodone being...
That's Vicodin.
Or the other drug. Yes, being a less addictive, right?
Oh, right.
That was how that was also...
Yeah, so the OxyContin was marketed to all these physicians as non-addictive, and they based that finding off of a letter to the editor in a medical journal, not even an actual research report.
Yes.
And literally it was just one sentence about people post-op that they didn't become addicted to OxyContin while inpatient. And they used that, then they quoted that time and time again, and hence this is where we are today.
The more you know.
The more you know. Hi everyone, welcome. This is Body, Brain, and Pain. I'm Dr. Erin Babineau, an orthopedic specialist and pelvic health physical therapist.
And I'm Dr. Kayla Conway, a pediatric physical therapist that specializes in chronic pain.
In this podcast, we will continue to dive into the ideas and research around why we hurt, the confusions and misconceptions that come with this, and how to be the best advocate for yourself in our ever-changing healthcare system.
Okay, everyone, I can hardly contain my excitement. This month, we're going to have something very special for you, a very special guest in the studio. Drum roll, please. Dr. Matthew Armfield. Matt Armfield is a MD who specializes in managing pain in children and adolescents at University of Minnesota Masonic Children's Hospital. Dr. Armfield, or Dr. Matt, as most people know him by, sees patients inpatient and outpatient, and is my right-hand man when it comes to treating patients with persistent pain. My favorite part about working with Matt is when we have our joint clinic visits with patients. We've been known to see patients together for a full spectrum evaluation, and we can't help but get extra animated and excited around one another, especially when it comes to talking about pain and how we can help people get better.
We love geeking out.
Absolutely. So Matt, first of all, thank you for being here today on this cool fall day here in the pediatric rehab office.
Thanks for having me. It's my pleasure.
Did I nail your intro?
Of course.
I want you to first tell the people, how would you describe what it is that you do? Just give us a little insight into your day-to-day.
Yeah, I am a part of a 5-member team here at Masonic Children's Hospital. There are 2 physicians, 2 nurse practitioners, and 1 social worker on a team. And our name is the Pediatric Pain and Advanced Complex Care Team. Other places you might refer to as pain and palliative care. So on a typical day, I meet with our team every morning for about an hour to discuss all of our patients that we're all seeing, because we split up between the 4 of us. And then I I go in the morning to see any of the patients who are inpatient, and those would be who have been admitted for a surgery and need good pain control after the surgery, those who have chronic conditions. I see all ages from premature NICU babies to I've had patients in their 30s because they were there.
Yeah.
That's usually in the morning, and then I have chronic pain clinic in the afternoons, and so I see patients there who have complex and chronic pain. I focus on helping kids with complex medical conditions that are causing chronic pain, help them through that, with a main focus on kids with pancreatitis.
And that's the group that I first met Matt on.
Yes.
Was our TPIAT group.
Mm-hmm.
Can you talk about how painful pancreatitis is?
It is, well, thankfully I've never had it.
Yes.
But from what the horrible stories that my patients have been telling me, I mean, it's extremely painful. Mm-hmm. And so generally it starts with same thing with adults too. It starts with a few attacks, and for the most part, they're pain-free in between these pancreatitis attacks. But then, which I'm sure you've talked about, like the same pain, the same spot over and over again, pain gets a lot worse and lasts a lot longer. And so eventually, with this untreated, they're going to have pain on a daily basis, even in between pancreatitis attacks, and it can really debilitate them completely, and so they're basically non-functional. And so we bring them in and get them ready for a major surgery where we remove the pancreas, mm-hmm. so it's theoretically not going to cause any pain. Mm-hmm. And then we replace the cells that make insulin back into the body, and so they generally don't have to take insulin. But what we found, though, too, is that even if you were just to remove that organ or stop whatever was causing the pain in the first place, because they've had pain for so long, that just even removing that wouldn't cure their pain. And so that's where what I like about this group is I treat their acute pain because they come in for a surgery, and so but also chronic pain. I see them on the inpatient side and the outpatient side, so it's kind of like everything I enjoy doing all wrapped up into one patient. But I see patients with a whole host of different medical conditions and different pain conditions.
Yeah, we need more Dr. Matts in the world.
Yeah, we do. I mean, luckily I get to work
with
them every day.
Yeah. Oh man. We're so happy to have you here. So thanks for being here. And I think as physical therapists, we get a lot of the medical management side, but only know briefly what's happening. And so we do a lot of just basic kind of education, but I think it'd be really helpful today to kind of go through the layers of this medication management.
Yeah.
And
mm-hmm.
I had a patient, we talked about it last week, and in my outpatient world, it's probably more similar to something like this, but where they're in so much pain that they kind of just stopped their home program with me. So they've really just stopped moving. They're not really getting out of bed, even though we had our 4 non-negotiables or 5. I can't remember. We use that now in clinic, so thank you, Dr. Matt. And so I had this person last week or a few weeks ago now who, really said, I'm not going to start moving until I see my doctor and we get some management with medication.
Yeah.
And of course, I'm in full support of that. But also, what, I guess, layers of management,
Yeah, and so I hear that a lot too. And medications can certainly have a place in a pain treatment program. The way I describe it to the patients that I see is that medications can be useful if they get you to the point where you can do the therapies that are going to cure pain. Because I'd say medications are not going to cure pain. They can help you get to that point, but the moment that you stop taking these medications, your pain's going to come back. And so if you're in so much pain that you can't even do any physical therapy because it does hurt so much that you need an appropriate medication just so you're able to do that, I think that's appropriate. If you need something to get you to able to go to school throughout the school day, then I think that's appropriate. With then every single clinic visit, evaluating their list of medications and seeing what we can remove, seeing what we can come down on, and so knowing that this is going to be a short-term plan, but it can be very, very useful short-term plan. So what medication was your patient wanting to start?
He honestly just wanted to get on naproxen.
Oh.
Yeah. But was told he couldn't be on it anymore.
Why?
Because of his digestive impact. Yeah.
Yeah, and that's the thing with all medications. They have side effects, some more than others, but there are also alternatives to a lot of these as well, which have fewer side effects. Again, the simple stuff that we usually start with, which I think are very appropriate, is Tylenol and ibuprofen, just those things that are over the counter. And they can be great in managing simple pain and kind of controlling chronic pain, although they generally don't do a great job with chronic pain. And what most people don't know is they can be taken actually together at the same time because they're two completely different medications. And so what you see with the medical management of pain is that we call it multimodal analgesia. And so you really are hitting the pain pathway from every different angle, medications, non-medications alike, from all the different types of where these medications work. And so they can be taken together. Naproxen's a long-acting form of ibuprofen, but for any NSAID or non-steroidal anti-inflammatory medications, so like ibuprofen, naproxen, Motrin, Advil, those medications can cause a lot of GI upset. They stop your stomach from producing the protective mucus lining of your stomach, and so you're at risk for ulcers. It can affect bleeding because it affects your platelets. It can have problems on your kidneys. And so, I mean, there's a whole host of stuff that you need to be aware of. But there's even another medication that's prescription called brand name Celebrex, which can give you the same good relief as ibuprofen, but has less effect on the GI tract and less effect on bleeding. And so just discussing these things with your doctor, and if you hear something, we need to get you off of this, asking like, well, what can I use, or what's safer, or is there an alternative to this? And then you can discuss the risks and benefits for that. There's the same problems with kidneys, for instance, for both medications. And so if you got kidney problems, that's one's not necessarily better. And so that's why it's important to kind of discuss everything with your physician. So generally, they're kind of just starting with the simple things because most people are familiar with that.
Yeah.
And then changing to different medications depending on their symptoms and depending on what they need.
Yeah.
And when you talk about these medications, I mean, already we've heard it, right? He's like, here's all the medications. He uses the fancy medical word for it. And then he says, okay, this is what you know it as, right? And then we say, but here's the side effects.
Yeah.
So right away we think, okay, these are medications we don't want to be on long term, which is exactly how a pain doctor thinks is these are short-term use medications that help you get to a place of function, right? We talk about this all the time. These are a mode to get you to a place where you can function. And then, like you said, then we start saying each clinic visit in a pain doctor's office, what do we need to go down on? What do we need to switch? What's working? What isn't? How can we? And it's such a even more reason you have to have these conversations with your doctor. Medication conversations need to happen with your doctor because they know all the side effects of things, what to look for, what to ask about, all of that.
I love it. And I heard you say earlier, that these, once you're off these medications, your pain's just going to come back. So let's
If you're not doing
If
it.
you're not
Yeah,
doing anything else,
exactly.
right.
Yeah.
So let's talk about that a little bit and the layers of medication that do get after our nervous systems at time. So that beyond kind of the over-the-counter stuff, what other type of things are you prescribing and why?
Yeah, the most common medication outside or prescription medication that we generally prescribe is a class of medications called Gabapentanoids. And so the big drug of that class is Gabapentin, brand name's Neurontin. And it has a cousin called pregabalin or Lyrica, which you might see on commercials on television for that.
Yep, absolutely.
So both of these medications, I like to describe it as just kind of calms your nervous system down. So when you've got chronic pain, you've got several hosts of different problems with your just overall nervous system. One is that your nervous system is extremely sensitive to pain, or even things that shouldn't cause pain do cause pain. And so these medications they work on what we call your peripheral nervous system, or the nerves in your body, not in your brain or your spinal cord. And it just kind of chills them out, kind of calms them down. Actually can be used for anxiety. I have mild social anxiety, and the strong anti-anxiety medications like Ativan or Xanax just like knocked me out, put me to sleep. And because I was familiar with this drug, I knew it. I talked to my doctor about this, and I started taking it for that, just kind of as needed. But the first few times I noticed how I was feeling, and that's exactly how I felt. It just kind of calmed me down, just to the point where everything was okay, and not it just kind of lowers the sensitivity of your nervous system. And so generally we start with gabapentin. For that medication, I see a lot of times that patients are on way too little of that. So finding someone who is very familiar with how to use that medication can be important, especially if you're trying it's not really work. First thing to check is make sure that you're getting an appropriate dose.
Yeah.
And if that doesn't work, then switching over to Lyrica. Insurance companies usually like us to start with gabapentin because it's cheaper. And generally one or the other tend to get some pretty good relief for chronic pain. So that's a medication that kind of acts on the body. And then there's another class of medications which are called Tricyclic Antidepressants. And they're not really great for use it as antidepressants, but we found that at low doses they can be good for treating chronic pain. And patients with chronic pain have, like I mentioned, oversensitive nervous system, but they have a dysfunctional inhibitory pathway. And so we've evolved to have special nerves that, when activated, they help prevent pain signals from reaching the brain. So if you've injured yourself, pain's a warning sign, and you get that initial insult, you got a whole bunch of pain, you get it treated, but you're still in pain, but that warning sign's not necessarily needed anymore.
Yeah.
And so you have this mechanism that your body can actually blunt those responses because it's like, yep, we got this, don't need this information
Danger
anymore.
gone.
Danger's gone.
Yeah. We got the antibiotic.
Yeah.
We took the nail out of the foot, all that stuff. Yeah.
All good. And so kind of it lowers that. And so you can actually activate that nerve. The best way is to do things that you really enjoy doing. And so if you're in pain, and then let's say you have a headache, but then start doing activity that you really, really enjoy, or you go out with friends or do something, generally, for the most time, if you think about it, or you probably won't think about it because it went away. Like your headache goes away. Yeah. And part of the reason is that when you're doing things that you really enjoy doing, it activates that nerve and pain signals go down. But there are medications that can actually do that as well. And the two medications, amitriptyline or nortriptyline, these tricyclic antidepressants, can do that. And so even there, again, trying to find also the right combination of medications, because a medication like gabapentin that works on the body paired with a medication like amitriptyline, which works on the brain, can be a nice combination because one works from bottom up and one works kind of top down. And so finding those right combinations that can help. And those have generally few side effects and are usually very well tolerated, even for long term. And so those would be a good appropriate medications for chronic pain. And then I think the third most common medication that I prescribe are actually lidocaine patches. And so these are things that you don't have to take by mouth. And so you just kind of slap on a few patches where you're hurting. And they work the best if you can actually just point to, like, this point hurts the most. And that can be a good kind of starting point for patients who are not really keen on taking medication every day, or not sure if they want to do that. And so this is kind of a safe way to go if they need something, just something supplemental to help with their daily pain.
Okay.
Are there any side effects to lidocaine patches?
Generally, the biggest side effect is like a contact dermatitis from the adhesive on the sticker. And like for the patients I see, because I only treat kids and adolescents, a lot of our younger kids just don't like the way the patch feels on their skin, and so they tend to rip it off. And so,
but it's more, you know, it's on your skin versus ingesting, so then you're not having as many systemic side effects as some of these other medications you're talking about. So again, a good place to start. That's
So I want a little sneak peek of what your play off with patients is. Throwing this at you guys. But partly I want that is because when you're prescribing these medications and you two are in the room together, that's Dr. Kayla and Dr. Matt, how do you set those expectations for people, especially families and kids? You know, what are your biggest rules where you're kind of having that conversation with medication, but knowing that we're trying to get after the nervous system all different ways so that they really grasp that?
Yeah. Matt always starts with asking them about all their medications.
So I do a very thorough medication history to find out what they've tried in the past, what worked, what didn't work, and especially any bad reactions that they've had. Especially for instance, patients who I know are going into surgery, that's going to be really important, so I know what to avoid and what not to avoid. And so again, if you've got complex chronic pain, any surgery or any other procedure can be much more complicated. I'm not necessarily difficult, but complicated, because you don't necessarily know how your nervous system is going to react to the post-op recovery. And generally, patients, I would suspect, have much more pain than would be expected, which can also be concerning for some of the medical professionals too. It's like, you shouldn't be in this much pain, but they are, which is another whole other host of problems. So again, having a good relationship with a pain physician or another physician who is well versed in treating pain can be important, just to making sure that you have a good medication regimen on hand for recovery. But after that, I focus the majority of our discussion. I spend 2 hours with a new patient, kind of going over all of this, but I really reserve the last 30 to 40 minutes talking about pain, talking about why the problems that they have, like I mentioned at the beginning of our conversation today, and then lead into, here are the things that you need to do to fix your chronic pain. And I know you guys have discussed that in the past. And then the last bit is, I always say this is the only optional bit, but for a lot of my patients, actually, because they have these really chronic conditions that just keep feeding into their pain, medications are generally, they are optional. You don't need them to get rid of chronic pain, but they have a really difficult time even functioning to get to that point. And so I will admit I'm probably a little bit more liberal on medications than most chronic pain providers, but I see a slightly different population than I would say that most people do. And so then I'd say we don't have to start them right now at this first visit. I certainly can. Again, it's the appropriate medications. And then if they're on inappropriate medications, like benzodiazepines like Xanax, Valium, Ativan, or opioids like morphine, oxycodone, Dilaudid, try to get those off of patients taking those as soon as they can, but safely also.
I was going to say, you don't ever just pull them away.
No, and that's important too, because I've had patients who have decided I just don't want to be on this medication anymore, and they just stop. And that's never a good thing to do without talking with your doctor first, because there can be very serious consequences and side effects from just stopping a medication that you're not supposed to. There are some that are safe just to stop, but there's some that are not. And so if you have, if you want to stop taking any of these, which is, we're always happy when we hear this from our patients, but you do need to have that conversation with your doctor, because in order to find the safe way to do that.
And I would say you are gifted at taking patients off of medications. I mean, but that's exactly why you need a doctor. And then especially when you're on a host of medications, to have someone who's as trained as you are in how can we safely, slowly wean these so that we don't have rebound pain, or we don't have, side effect, big reactions to getting off of these medications. And I mean, people are successful with it.
It really gets also, all of us are involved in getting their confidence up that they realize that they are able to function without the use of these medications.
Right, yes.
Or they get to the point where they don't like how that makes them feel, and they would rather just not be on them because they want to live a normal life without medication. They're realizing that, hey, I can do that. Yeah. And so we're motivated to get them off. They're motivated to get off. And so that only makes
it becomes successful.
Extremely successful.
Yeah. And it's done in a successful way. And so he talks about all that stuff, and then he throws it to me and he goes, Kayla, you got anything? And I'm like, yeah, we talk about function, and then we say, and by the way, you're going to come to see me in the clinic, right? And we're going to work on all of those things that Dr. Matt just talked about. And I'm going to be asking them, how are you doing? Where's your medication at? And they will then come to me and say, hey, I don't know if this medication's quite working. So then in pain rounds every other week, I get to say, hey, Matt, I don't know where you can go with someone's gabapentin, but like maybe we need to go up, consider going up. Like, what do you think? Yeah. And then we get to have a discussion in between their appointments with Dr. Matt, because we get to say, oh, they're doing really well in this, but they're super sleepy, or they're not sleeping quite as well at night. Let's talk about this. So
some of those side effects,
So it's a cool thing we got going on our team.
It does sound pretty cool.
Yeah.
I'm jealous. I wish I had a pain team. I'm in the private practice world. And
hey,
you
can always start one, Erin. You can always start one. Right. It had to start from somewhere.
I actually, I want to ask the question, and we've talked about it on the podcast, but I think from a medication standpoint would be really helpful, especially in the outpatient world. Because I get that all the time where someone's like, I want to get off this gabapentin, so I'm just doing it. And I'm like, no, talk to your doctor. Let's have a plan. But can you explain what happens to your nervous system if you just bluntly stopped taking that?
It depends on the medication.
Yeah.
And so for gabapentin and pregabalin or Lyrica, those, I don't know if pregabalin was, but I know gabapentin was originally developed as an anti-seizure medication. And then I found it didn't do a great job at controlling seizures, but it did a great job at lowering nerve pain. So the risk there is just stopping that could bring on seizures, because it would help prevent them. So if you just, basically the concern is like anything that it was treating, the opposite that could happen, just to that much higher degree.
Right.
So for opioids, for instance, you have the classic withdrawal symptoms of jitteriness, feeling awful, vomiting, sweating, diarrhea, and obviously increased pain, insomnia, and basically all the opposite of what you're doing for opioids. Now, opioid withdrawal is not going to kill you. You're going to feel like you want to die because it's just so awful, so I would not want anyone to go through that. But even just stopping cold turkey, even if you know what's ahead, can have some very serious consequences too, and could be very unsafe depending on your state of health. Regardless of pain, the stress that it puts on your body can be quite severe. And so, I mean, other medications, other antidepressants that I commonly use, each have their own set of risk factors and other things that might happen if you just stop them. And so that's why it's really important to talk to your doctor about if you want to start coming down or stopping.
Yeah, I like that term, just like the stress it's putting on your body, just to simplify it for people. Because I think when we think about medication, we're thinking, oh, it's only helping me, which it is, but it's also changing your nervous system, different parts of neurotransmitters and things like that. And I think that's what's important to understand. The opposite can happen. So,
Wow. I think this is a good place to stop. I mean, we could talk all night long. We really could.
Yeah.
I think we've answered most of the questions that we had.
I think we have to have Dr. Matt back on.
Oh my gosh.
We're going to talk opioids.
Please come back.
We're going to have a whole episode on opioids.
That's a big topic, which I know we didn't really talk much about now because it just deserves its own one episode, and because that has its own challenges. And actually where it fits into treating chronic pain is controversial. And they can be useful in some regards if done safely and closely monitored, but just the education around those medications, because I get a lot of those questions all the time too.
Totally.
Like, even parents of our NICU kids worried about addiction or potential for addiction for all these, is because you're hearing about it in the out there in the world, and so when doctors start discussing these, those are completely valid concerns, and those concerns should be brought up with your physician. And hopefully you'll get, and for any of these medications, you should know why you're taking them. You should know, again, all the side effects that could be on there, or the most common, what's most likely. Because if you look these things up online, you'll just get everything under the sun, and then you can everything causes cancer.
Dark hole.
Right. So I wouldn't necessarily recommend that, but finding someone who is familiar with, this is generally what I see that that's happening. And just, I want all my patients to know why they're doing every single treatment, because if you know why you're taking a medication, if you know why you're going to physical therapy, if you know why this, if you know why you're in pain, if you know why these medications help with that pain, that only empowers patients to actually do the therapies or to continue taking the medications. And again, it only helps build up expectations. The greater expectations you have for that something's going to work, the more likely it is going to work. But the opposite's true. If you don't think something is going to work, especially if you don't think a medication is going to work, it is not going to work. And they've studied this. They've shown this in humans. They've also shown this in mice, actually, which is fascinating. And the totally geeked out research article I read with talking about mice and chocolate and hot plates and
Okay.
Awesome. So stay tuned, ladies and gentlemen, when we have Dr. Matt on, because he gave you a big old teaser just now.
To morphine,
I love that, though. But I love that you're reiterating everything we say all the time on this podcast, which is you need to take an active role in getting better. So by understanding these pieces of it, understanding why you're taking the medication you are, understanding why you're going to physical therapy, understanding all of these roles is going to help you be able to advocate for yourself and get better.
And the last thing for medications, a lot of these weren't originally developed to treat pain, and so you might say, why are you starting me on an antidepressant?
Right.
I'm not depressed, I'm not crazy.
Yep.
It's no, I know you're not, but we've seen that this can help pain. So don't take these even at face value. That's why I say it's important to know why you're taking them,
why you're prescribing it.
Why don't get a good answer, you need to ask again and keep asking until you really understand. And if you don't understand, again, keep asking. And if your doctor doesn't explain it differently or explain it that you can understand, ask someone else.
Yeah.
Oh my gosh, I get that all. It happens weekly. Someone's put on an antidepressant for their pain, and they're livid about it. And it's I'm the one starting to explain, well, this is why we do it.
Yeah.
Right.
And then, kind of saying, man, I wish, your physician had every, good intent with this prescription.
Yeah.
And unfortunately, it's most physicians don't have the time.
Oh, absolutely.
In the clinic office to explain all this stuff, but it's so unbelievably important, and that's what's really sad about this. I have the great luxury of spending 2 hours with a new patient and then spending a full hour with my follow-up patients because it takes that much time.
Yeah.
But I couldn't be in private practice because I wouldn't see enough patients to
make
a living.
Make
Yeah,
it lucrative, which is,
Yeah.
I mean, who do you want? A doctor that wants money or a doctor who wants you to get better, right?
Yeah, but you also want a doctor who can actually live.
Yeah, oh yes, we talk about that all the time. Absolutely.
Oh, man.
All right, so
Yeah.
we have started a new tradition on the podcast, and we talk at the end of every episode. We talk about what brought us joy that month, that week, that year. So, Dr. Matt, what is bringing you joy these days?
Right now, I realized I was 3 seasons behind of the Great British Baking Show, and so I'm binging that.
Yes.
And so that is causing me, giving me wonderful amounts of joy, and maybe motivated to start baking again.
Oh, I love it.
What do you bake?
I have been known to bake cupcakes. In fact, in medical school, I ran a small, and it uses a very loose term, cupcake business.
Did you have a name to this cupcake business?
I was the cupcake doctor.
Yeah. Oh, that's so good. I did not know this. I've known Matt for a long time, and I did not know this.
My slogan was, "Trust me, I'm a baker."
That's good.
Gosh. Oh, I think we need to bring this back. Bring it back. Yeah, so stay tuned for Dr. Matt's Cupcakes. Wait, what was it called?
We call you Dr. Baker.
But what did you call? You called yourself Dr.
The cupcake doctor.
The cupcake
Oh my
doctor,
gosh.
sorry.
So stay tuned for the
Post
cupcake
the
doctor
recipe
coming
on
to
your podcast
Oh,
notes.
that's please.
I love it. Oh my gosh. I love it. Okay,
If you're willing
awesome.
to share, we'll take it.
Oh, this was so great. Can't wait to have you back.
Yeah, thanks so
That'd be
much,
good.
Dr. Matt. Yeah.